With that said, it's 2:15, and as I mentioned, oh, go ahead, Michael. Did you want to
No,
say
I just wanted to
something?
say thank you. I was really excited about the talk, so happy to join.
So, as I said, I jumped on about 5 minutes ago and said, wow, I'm hosting and I feel like I'm late to the party. But welcome to each of you. Just really quickly, my name is Jill Cizek. I work specifically in the health sciences with Dr. Bashir as Vice President for Health Sciences. So we really try and do programming and support investigators across all of the health science schools. And the best thing that we can possibly do is what's happening here today, where we bring investigators from all of the health science schools together, at least starting to have conversations on critical topics. So I actually want to also thank Dr. Clark, who's an associate professor in Farm and Tox in the Jacob School, because he brought this to us. And this was pretty exciting. It fits well with some of the other programming that we have upcoming. And I'll just mention quickly, many of you should have gotten already. And if you haven't, I'll put a link in the chat, an invitation to Dr. Valco, Nora Valco, who is the director of NIH NIDA, who's going to be presenting to all of us on April 1st. But Dr. Clark brought this to us as part of his R21. And for those of you that are early career investigators or maybe less familiar, it's really a great mechanism. And we thank him for applying for it. And even better, thank you for getting it and bringing the award into the university. But it's really an excellent mechanism to go out and collect data on really critical topics and push all of your fields forward. So with that said, thank you, Dr. Clark. And I know that you would like to introduce Dr. Weissman.
Yeah, so thank you to the Office of the Vice President for Health Sciences and Jill for really helping set this all up. And so just wanted to sort of give a little bit more context as why we're doing this seminar. And it's not just a single seminar. We've organized 3 for this semester as a lead up to Nora Volkov's visit on April 1st. She's the director of NIDA. And so the R21 that we received is through the Helping End Addiction Long-Term, or the HEAL initiative. And as part of that, the mandate is to include people that have lived experiences. And this includes, of course, caregivers, physicians, and people who are struggling with opioid use disorder. And so the idea is that the HEAL initiative wants you to bring these perspectives into your research, to more contextualize it, and to make you grounded in what you're doing. And just to just echo something that Jill said, the R21 is a fantastic mechanism. In our hands, this mechanism is a proof of concept. We have a potential drug target to curb opioid intake and seeking, at least in rats. We've shown proof of concepts in cocaine, and now we're doing it with opioids. And so without further ado, our guest today is Dr. Arthur Weissman. He's a Buffalo native, Williams South High School, and a graduate of UB Med School. He has been in the role of program director for the Addiction Medicine Fellowship here at the Jacob School for the past year and a half. He's also a staff physician at DART Methadone Clinic in the Endeavor Health Services. He's been recently awarded the Erie County Medical Society Mentor of the Year in 2024. And frankly, I think we're lucky to have him. I looked at his CV and he is hotly sought after, many talks recently. And so I'm glad to see that he's been able to squeeze us into our schedule. Thank you, Arthur.
Okay, well, thank you, Stu. And thank you, Jill, and everybody for inviting me. I'm very happy to be here. It's very exciting. And I know you kind of adjusted the time to fit my schedule. So thanks very much. Maybe I will try to share the screen. See if we can make this work. I don't know if there's any sound in this, but I'll share the sound.
I don't have any restrictions on it, so you should be okay.
Okay, I think you should be able to see this. Now let me fire up the ever-present PowerPoint. Hopefully this won't be too bad. Can you see that? The Division of Addiction Medicine?
Yes, we can.
Perfect.
You see that? Yep. Great. So that's our spiffy new logo in the department. So anyway, thanks for having me. So I thought we'd talk about an introduction to addiction and opioid use disorder. That's me. And just my background, that was me about a million years ago. My background is actually in surgery. I used to be a general surgeon. I'm an addiction doc these days. I work at DART, which is one of the methadone programs in town. I work at Endeavor, which is a dual diagnosis kind of place. It's kind of like Horizon, but a little smaller. And I work at ECMC. I run an elective for our medical students. And here, let me get rid of that. And I'm the program director for our fellowship. We have an addiction medicine fellowship, and I'm dual certified in general surgery and addiction medicine. And I have no conflict of interest disclosures. I do not have stock in a methadone company. And if you have questions, please let me know. I timed this. This runs maybe like 40, 45 minutes. Try to leave a little time for questions at the end. So I thought we talked about the disease model and some lived experience. I was told you were interested in lived experience, which I have. And then like a little introduction to medications for opioid use disorder, kind of from a clinical perspective, what I do. But I want to start with a question. And let me see if I can make this work with the polls. And maybe it's not going to work as a poll. I don't see the polls here. Maybe the polls aren't enabled. So we don't need the poll. So
you should be able to, Dr. Weissman, but while you're chatting, let me see what's going on.
we don't quite need it.
You sure? Okay.
Yeah, for some reason I don't see it. That's okay. Anyway, so here's a question. How effective do you think treatment is for addiction? If we had a scale of 1 to 10, there's our scale. And so if a 1 is it never works, and a 10 is it always works. And I want to see what people are thinking. And could you, I don't know, maybe like unmute and shout out some numbers?
I think people are putting them in the chat for you.
Bring them in the chat. Let me see if I can get the
I know,
chat.
sorry, you probably have multiple screens up. I'll read them off to you if you want. So we've got
I can see the chat.
Okay.
All right.
3s, 4s, 5s.
Right. Now this is, you guys are a little conservative here. So I kind of gave this same talk yesterday for our department, and I was getting like 7 8s. So folks are a little conservative, which I like. Now I think this number might be a little inflated because I'm an addiction doc, and maybe you're trying to be polite. But let's say, for the sake of argument, I'm just kind of looking. Let's say a 5 as like the average. Maybe let me put that little window up. Let's say a 5. I'm going to show you some of our own numbers later. Okay. Could somebody volunteer and give us a definition? Anybody?
I can give it a go.
Okay, great.
Being a basic scientist.
Okay,
the compulsion to seek out and take drugs regardless of negative consequences.
That's almost exactly what's coming up. So very good. Thank you.
And Michael in the chat wrote behavioral compulsion.
Okay. The thread is the compulsion. So this is really pretty cool. I ran across this. If you take the word and you split it into its components. So the ad, if you remember your anatomy, adduct, abduct, adduct, the ad is toward. The dict, the root comes from command, like dictate, dictator, dictation. So toward the command, it's like what you would say to a slave, right? Compulsive. So a good working definition is just exactly like what Stu said, compulsive use despite negative consequences. That's a pretty good working definition. What we use are the DSM-5 criteria from the Diagnostic and Statistical Manual version 5. So they're pretty much the same for most of the substances. There's a few tweaks. But say, for example, for opioid use disorder, there are 11 diagnostic criteria to choose from. And could you guys, let's take a minute or two, could you guys kind of shout them out or put them in the chat? So these are the 11, because we're really familiar with this. It's so common, right? substance use disorders are so common. So you guys kind of know this already. Could you just, shout them out or put them in the chat? So what I'm looking for is the 11 diagnostic criteria or like symptoms for opioid use disorder. Can you come up with them?
Paul said in Dutch the word is verslaving.
Oh, I like that. For addiction? Really? That's cool.
Yes. Yep.
Okay.
Brooke says using a medication substance for its unintended purpose.
That's really interesting. I can't quite make one of the criteria conform to that, but I like that. What keep going. Anybody come up with anything? I'll give you one just to see what, so like withdrawal, for example, is one. Anybody else? Wanting
Kim says, go ahead.
right, yeah, I can see that. Wanting to stop when unable to, yes, that's one. So failed attempts to control or cut down, or persistent desire to control or cut down. Tolerance, right? Let's see what else is here. Keep going. You guys are on the right track. Anybody else? We'll give it a second, then I'll go ahead. The medical students typically they love this because they're so competitive. Okay, craving is one, right? They took legal out of DSM-4 and substituted craving. Subversion of other activities. That's a wonderful way to put it. Yes. So curtailing normal activities, right? Not able to function without it is pretty good. So friends or acquaintances. So screwing up your relationships is one. Craving that mitigate withdrawal symptoms. So we got craving already. That's pretty good. Let me, you guys did good. Let me give you the rest of them. So they are withdrawal, and I have a free mnemonic device that's coming because I thought this is helpful to keep this in my head. Withdrawal, craving, failed attempts to control or cut down, screwing up your health and continuing to use, putting yourself in hazardous situations, giving up normal activities in order to use, using for greater periods of time or greater amount than planned, screwing up your roles, homeschool or work, screwing up your relationships, tolerance, and time, spending an inordinate amount of time pursuing all this. All you need is 2 over the last year, and the 2 don't have to be at the same time. It goes 2, 4, 6, mild, moderate, severe, and they need to cause clinically significant impairment or distress. So it's pretty subjective. Here's the free mnemonic device, W chart, 1 W, 2 each for C, H, A, R, and T. So that's how I keep them straight. Here's another question. Is addiction a disease? Here's your options. Yes, sort of, not really, and no. And maybe I'm seeing, thank you for getting, I'm seeing, boy, everybody's saying yes. When I do this question with the medical students, they're scared. They look scared for a second, and then they figure out they're supposed to say, is it transmissible? That's a very good question. So I'm seeing mostly yeses. And the reason why I'm spending some time with this, is it really a disease? Because I mean, this is who gets into the disease club is really important, from my perspective as a doc, and I think really any clinician, because that's who we're going to treat. I've taken this part from this guy, Kevin McCauley. He's very interesting. He's got some really good videos on YouTube that you can watch. He's got one called Pleasure Unwoven. That's really good. He used to be a really interesting guy. He used to be the flight surgeon for the Blue Angels back in the day. I met him. He's a very interesting guy. So what I'm going to do is start with the opposite point of view. Sometimes it helps to look at the opposite point of view with things because it helps clarify your thinking. So this is the choice argument, also known as the moral model. So this is the best argument against the disease model. It's pretty simple. It says that using drugs is a behavior and all behaviors are choices, and addicts they choose to use drugs and they can stop using anytime they want to. They just don't want to. We can do a little thought experiment to illustrate this. So you get yourself some alcohol. You get yourself a person with alcohol use disorder. You get an extra point if you know the name of that actor. Anybody? This is a generational thing. That's Gregory Peck. And then you say to the person with alcohol use disorder, go ahead, Mr. Person with alcohol use disorder, have a drink. It's on the house. But if you take the drink, I will then shoot you in the head. This is not recommended as a treatment strategy. Now, I think you'll probably agree with me in this little thought experiment that unless there's something else going on, unless the person is suicidal, psychosis, acutely intoxicated, acutely in withdrawal, encephalopathic, unless there's something else going on, if you hold a gun to the person's head, they will be able to, in the moment, not reach for a drink. I think you'll probably agree with me. So that's, one way to look at this. The choice model is if you threaten people enough, you can get them to stop. Now, we do this all the time. Like, this is how drug court works, right? Now, this is the point. You can't do this with other things that we think, are diseases, like cancer, for example. You can't hold a gun to the head of the person with hairy cell leukemia and say, don't have that. That's not going to work. So this used to bother me, this difference and, but this ability to choose. So, but there are some problems with the choice argument is that number one, it ignores a lot of evidence. And number two, we're trying to get our learners to practice evidence-based medicine, and we're trying to practice evidence-based medicine. And it creates this moral trap for us as providers that's really easy to fall into and is very counterproductive. Now, granted, people with addictions can display a lot of disgusting, unpleasant behavior, but there's a long history in medicine that if a disease has really disgusting, unpleasant symptoms, and we have no clue as to the real pathophysiology, especially if the brain is involved, or sex, or pleasure, then we tend to default to they're bad. We want to turn it into a moral thing, and we want to blame the patient for having this. I'll give you some examples from medical history. Syphilis, cholera, and tuberculosis. These were all thought of as emotional problems or personality problems or moral problems before we figured out the real pathophysiology, that they were infectious diseases. So why is this important? Because this moral model, choice model, it's not a really good treatment strategy. It doesn't work. It backfires really spectacularly with people with substance use disorders to try to shame them into changing their behavior. It really backfires because of the way addictions work in the brain. And the way addictions work in your brain is addictions work in your midbrain. Addiction lives in the midbrain, and your midbrain is all about the 4 F's. If you know what those are, they are food, fight or flight, and romance. So what does your midbrain normally respond to? This would work better if it was like a little later in the afternoon, but did anybody not have lunch in the crowd? Anybody? Let me look at everybody here. All right. Well, if you didn't have lunch, if you're hungry, could stare at the screen. I'd like everybody to stare at the screen. Ready? Don't blink. Ready? Boom. I just did a little experiment on your midbrain. So your midbrain is designed to respond to things like chocolate cake and sex, and you get another point if you know the name of that character, and not really carrots. And I apologize if you're a vegan or vegetarian, but this is about survival value. And if you're starving, your midbrain really doesn't want you to be thinking about carrots. So the way this works is that guy, does anybody Anybody know what that is?
One of the Simpsons, I think.
Yes. Well, that is specifically dopamine, which is responsible for the synth. Oh yeah, well that was Milhouse.
Oh, the previous slide. Sorry. Yeah.
No, I thought you were talking about dopamine. No, that was Milhouse. You're right. You're correct. That's Milhouse, which actually is relevant for this discussion. Milhouse, right? Because he was named after Nixon, Richard Milhouse Nixon, who and the whole war on drugs was his idea. That's a lot to do with why we're talking about this. Anyway, not to digress, but that's dopamine. And the old thinking was that it was the pleasure chemical. The new thinking is it's about salience, which means it stands out, reinforcement, which means do it again, and really wanting. This is the chemical that really makes us want things like very badly. So the way this works is that if you have a little bite of chocolate cake, there's a little blip in dopamine release in your nucleus accumbens. And if that rises to a certain level, that's called salience. And salience means your midbrain says to you, dude, that was really good. You should pay attention to that. You want to do that again now. And dude, that was really good. So that's how your midbrain sounds, or at least mine. And now if you smoke methamphetamine, which is the drug that does this the most, it does this. And so there's a few things to notice. It's like 10 times higher than anything you can normally achieve physiologically with anything else. It's way faster. You see how the slope is way faster. And I made the animation really fast. It just goes boom. And that's called the rate hypothesis when it's faster. So the faster something gets into the brain and the faster it gets out, the more addictive it is. The rate hypothesis. And it crashes down below the baseline here at the end, because our brains are really not built to keep up with this, to generate that much dopamine. And they're barely built to keep up with chocolate cake, I think. So the drug causes this dopamine spike and crash in your nucleus accumbens. The drug hijacks these survival pathways in the brain. Your frontal cortex, which is up here, which is where we do think and we make moral decisions and do all that stuff, that goes offline, because your brain is interpreting this as a stress situation. And when your brain thinks it's a stress situation, it doesn't want you thinking about things. It wants you to react for survival. So this is what we think is broken in addiction, the stress hedonic system. Hedonic means pleasure. We can show you some fancy pictures from Dr. Volkow. Well, I'm so excited that she's coming. So this is showing the dopamine receptors being downregulated with methamphetamine, the orangey red. And this is showing the frontal cortex going dim with cocaine. So that frontal cortex shutting down. So people not really being able to think very well. There's more to it than this. There's more systems involved. So this stuff I've been talking about, the dopamine stuff, that's the compulsive use part. And I think that's the central thing, because in the animal models, you people that are like way more scientific than I am, you know that if you partially block that system down, the animals use more to try to overcome the blockade. And if you ablate those tracts, if you cut those nerves, they stop using pretty quickly. Then people go into withdrawal. That's a learning process, and withdrawal is very aversive. And people learn that if they use, the withdrawal goes away. And then it does project into the thinking parts of the brain. And that's where people get cognitive distortions like obsession, preoccupation, anticipation, and then they use again. So it's this cycle that keeps going around and around and around. So this is like the state of the art right here in terms of, the pathophysiology of addiction. So, and again, if you have questions, just yell. We're talking about this, of course, because, we're still in this overdose death epidemic. The overdose deaths in the United States, over 107,000 per year, largely driven by opioids. This is true locally as well. This is the Erie County overdose death numbers. You can use these same graphs and just change the labels. You can use them for hepatitis C, for neonatal opioid withdrawal syndrome. So the babies are going through this too. This is, if you follow the news, this has been in the news lately. This is very exciting. So this is actually, it's kind of a complicated story, but the CDC evidently, they do some fancy modeling, and they do these predictive curves. And what they do is they look at like March 2025 and compare it to March 2024. So it's like the month end, and they compare it with the month the previous year, and they do some modeling, and they come up with a predicted value, and then they wait for the reported value to come in, and you can see it's pretty close. So what they think is, what they've seen is, the past few months, it's really gone down substantially for the first time in a long time. The overdose deaths declined 24%. So we may be seeing some light at the end of the tunnels, and there's various explanations for why they think this is so. It might be, all the Narcan that's out there. So the deaths in Erie County are largely related to fentanyl and or cocaine, which is very dangerous. So, what started this, we've been through these various waves of these opioid epidemics in the United States since like the late 1800s. But this latest wave was, what started this was, well, if you're as old as I am, and there's a few of you here, you'll remember this. This was in the 90s, and this was the marketing of OxyContin. So it was these hats that started this. And I remember these salespeople coming around, and they would tell you that if you prescribed opioids for pain, nobody gets addicted. And they were lying, and they knew they were lying. And this was all, very profit-based. So this doesn't make any sense to talk about if we don't have effective treatment to offer. And that's why I ask you guys that question about how effective do you think treatment is? So the traditional view is that you would maybe detox people. And detox is actually not a very good word. It's not removing toxins. Okay, you're managing withdrawal symptoms. That's what detox really means. So traditionally, you would detox people, and then they go to rehab for 28 days. If they have insurance, that'll pay for that. And now you're cured. Like, I don't see why would you want to use, right? The trouble is that doesn't work very well, to just like detox people for a week and then let them go. That's because when the patient gets out of their detox admission, they will call their dealer from the parking lot, because they're still craving like mad. You haven't really fixed what's going on in the brain. So if you don't arrange for effective treatment after you stabilize people, after you detox people, their survival is actually better, like 7 times better, if they actually abort detox and leave early against medical advice. If they leave early while they still have some tolerance to protect them. So this brings up what's called agonist therapy for opioid use disorder. Agonist therapy means buprenorphine or methadone. The goal is to eliminate or markedly reduce non-prescribed opioid use. So here's a little pharmacology, which probably most of you know way better than me. So methadone is a full opioid agonist, a full mu opioid receptor agonist. So it has this classic S-shaped dose effect curve that we know and love. So an agonist means it turns the receptor on. So if you give a little dose, you get a little effect, and then it starts to climb because it's really starting to work here. And then it starts to level off because you're starting to saturate the receptors. But it's because it's a full agonist, there's like no end in sight. It still goes up. So that means you can get respiratory depression and overdose up here at higher doses. Buprenorphine is very interesting. It's a partial agonist. So it starts out the same way, but then it levels off like halfway up. So you can give more over here. You don't get more effect. That's called the plateau effect or the ceiling effect, which means it has minimal respiratory depression and a really good safety profile. It's really hard to kill yourself with buprenorphine. And it has, interestingly, it's got very high receptor binding, receptor affinity. It really binds very strongly to that receptor, even though it only turns it partway on. So that's a really interesting combination. And because of that, it can actually kick other opioids out of the receptor if they have less binding affinity, and it can keep them out to a certain extent. It's kind of a dynamic process, but it can largely keep them out. So then you have naloxone, which is what's in the, when you are giving somebody the spray up the nose for overdoses, or a cousin, which is naltrexone, that's in a medication called Vivitrol that we're going to talk about in a sec. So those are antagonists. So those turn the receptor off. So you can think of those as down there. Okay. There's methadone. Always kind of weird looking molecule to me. So full agonist. And in the United States, you have to be enrolled as a patient at a methadone clinic to get methadone for opioid use disorder, which is a little weird, the system here. But so you have to be enrolled at a place like DART, where I work, to get methadone. That is not an espresso machine. That is a brand new methadone machine. So we have a few of those at DART, and the electronic medical record plugs right into that. So my orders go right into that. So you got to be careful because of that full agonist thing. So you got to be careful with that. There's buprenorphine, another weird molecule, even weirder. And the triangle thing amazes me. Like, what does the triangle do? So anyway, the partial agonist, again, very high receptor binding. That's what a Suboxone 8 looks like. It's buprenorphine naloxone. That's what the 8 looks like. They're actually very small because it's designed to go under one side of the tongue for sublingual use. So it's supposed to melt right under the tongue. There used to be this thing called the X waiver. And the idea was they wanted to make this all special. So the doctor had to get this special training and sit through all this really crazy, boring training to get this special thing added onto your DEA number so you could prescribe this. They got rid of that because it was a barrier. So the push now, and the meaning behind this was very clear, is let's try to make this treatment a lot more available. So that's what we're trying to do now. A word or two about Sublocade and Brixadi. So there's somebody getting a Sublocade injection. So Sublocade and Brixadi, those are extended release buprenorphine, and these come in monthly and weekly injections. They're sub-Q injections. And these are good for patients that have transportation issues or other barriers to keeping appointments, like they have trouble getting to appointments. It takes diversion off the table. There's some diversion with every controlled substance. And it takes that off the table if that's a concern. And some patients really like this idea. They really like, they just get the shot, once a month, and they're good to go. And they almost, like some people, they feel like it's kind of shaming that they take this buprenorphine every day and take a film every day. And they feel like this is better. Like they just get the shot, then they're done. They don't have to worry about it. So they like that. Now, Naltrexone is an antagonist. It comes in 50 milligram tablets. This is the cousin of naloxone. And it also comes in a monthly injection version. And that's what you're seeing there. And for opioid use disorder, it's recommended that we get the patient, if they're going to be on naltrexone, which there aren't too many people interested in it, but there's a few. If they're going to be on that, the recommendation is you get them on the injection version because it has better adherence or compliance is kind of a bad word for it now, but people stay on it better if they're on the injection version. And it maybe works better because it has more consistently a little higher therapeutic blood levels. So it maybe works better. It blocks opioid reinforcement and craving and protects people from overdoses. And it's also interestingly indicated for alcohol use disorder, which is weird. Why is this opioid blocker approved for alcohol use disorder? That's because part of the reinforcement from alcohol comes through the opioid system. And I was reading about this the other day, and they said if you have opioid receptor knockout mice, right? Mice that are genetically engineered to have no opioid receptors, you can't get them to drink alcohol, which is really interesting. There's some issues, though, with naltrexone that before the injection, people are supposed to be completely off other opioids and then have a 7 to 10 day washout period where any residual opioid effect at the receptor has gone away. And that can be difficult for patients to tolerate that much withdrawal. So there's a high dropout rate before you even start people. And there is very questionably, whenever this is looked at, like, does this really reduce overdose mortality compared to buprenorphine or methadone? It's hard to show that. But it can still be, it's an option. It can still be an option in the right patient. And there's a few niche markets for naltrexone, for people where that might be a good idea. So here's a little comparison slide, which is methadone versus buprenorphine versus naltrexone. So methadone is a full agonist, buprenorphine is a partial agonist, naltrexone is an antagonist. There's more structure in methadone programs, there's less diversion, there's no precipitated withdrawal. We're going to talk about that in a minute. Buprenorphine has that really good safety profile because it's a partial agonist. It's really hard to kill yourself with buprenorphine, and it's a lot more convenient because you can do it office-based. There's no diversion with naltrexone. Again, it's office-based. There's no withdrawal if you come off it, which is kind of a plus minus. Disadvantages with methadone are you got to be in a methadone program, which is not very convenient for a lot of people. There's more diversion with buprenorphine. That partial agonist effect may not be enough for some people. And they'll tell you, yeah, I was on Suboxone for a while. It didn't work for me. Why didn't it work? Oh, I always felt lousy on it. I felt terrible on it. It never worked. And a lot of those people, you get them on methadone and then they feel normal. And there is this possibility of precipitated withdrawal. I'm going to talk about that in a sec. There's issues with naltrexone in terms of getting people started on it and keeping them on it. There's a high dropout rate. And does it really decrease overdose deaths? Certainly not as well as buprenorphine or methadone do. There's a lot of information there. Anyway, so let's say you've got a patient or a client, whatever, that's opioid tolerant. Say they're using fentanyl. Fentanyl, full agonist, right? So it's got that full agonist S-shaped curve. And let's say your patient is living up there on fentanyl. What is going to happen to that person if you give them buprenorphine? And there's the buprenorphine curve to remind you. What's going to happen to that person? I'll look up here in the chat. Anybody? What's going to happen to that person?
Withdrawal.
Yes. Yes. So the hint, I didn't get to the hint yet. The hint is buprenorphine, partial agonist with very strong receptor binding, receptor affinity, can kick other opioids out of the receptor. So that person is very quickly, like within a few minutes, they are going to go from up there to down there. And how is that perceived by the patient? As withdrawal or very sudden or precipitated withdrawal. Now, there's this old myth in medical school that they tell the students, and I was told this back in the day, oh, opioid withdrawal never killed anybody. That guy's just a whiner, and that is not true. People do die from opioid withdrawal, and this precipitated withdrawal is like extremely unpleasant, hazardous, aversive. So there's various strategies to try to minimize the risk of this precipitated withdrawal, which is especially relevant because there's so much fentanyl out there. And so what we do, I just thought you might like to see this, how we do this. So at Endeavor, where I work, if I'm on call, I may get a call from the counselor and she'll say, well, here's a rapid access for you. So if somebody called Endeavor and said that, I need help. I'm using fentanyl. I need to get off of the fentanyl. So the counselor calls me and says, can you call this person? And you just call them and you get a little information on the phone. You don't need very much. And then this is actually a full page on a PDF. And I made it so big because I can text this to people. I have like a secure spoofing doctor texting apps called Doximity. And I can text this to people and this looks pretty good on a phone and people can read these directions. So this tells, and the whole idea with this microdosing is to try to avoid this precipitated withdrawal. You're starting with very, very, very tiny doses of the buprenorphine. So you're trying to kind of sneak up on the receptor and give a little tiny dose until the person can get used to it. And you do that for a few days and then you ramp up the dose. And this can work really well. There's another page which tells them, so I send them a script for like 5 2s. the films come in 2s, 4s, 8s, and 12s. So I send them, the smallest strength film, which is a 2, and I tell them, cut it into, get an 1/8 of a 2 and start with that. And this can work really well. And then it tells them to ramp up the dose once they can tolerate that. And this can work well. It's a little complicated, but this seems to work. Another strategy is macro dosing, which is just what it sounds like. And that's where you just tell the person to pound a lot of Suboxone right up front, like 32 milligrams, where you're trying to just overwhelm any precipitated withdrawal, like just keep going. So you can do that, or you can do this. This is very state of the art. And we just started doing this at the ECMC, a cross taper. Now you have to be an inpatient for this, but this can be a nice option for people, especially if people are, you start talking to them about the precipitated withdrawal, or maybe they've had some very negative experiences with that before. So you can say, well, listen, we got this thing you could do. You could go to the ECMC, and the way you do this is you do like a 5-day thing, and you give them a methadone taper, and you start with doses like this, like 30, 30, 30, 20, 10 milligrams for each day. And then at the same time, you slowly ramp up the buprenorphine, 1, 1, 2, 4, and 16 milligrams. So the methadone is kind of covering up any of that precipitated withdrawal. This can work really well. This works really well. We've been doing this for a few months at the ECMC, and this gets the patients through this, and it always works. It's pretty simple. So here's a you may be thinking moment. How does any of this make sense? How can you treat opioid addiction with another opioid? Aren't you just replacing one addiction with another? I get that question a lot. There is a point there that buprenorphine and methadone are both opioids. You probably figured that out. But buprenorphine and methadone have some unusual properties that make this work. So you have to go back and look at fentanyl and how fentanyl works. So the person injects, they get this spike into the blood and into the brain, which should remind you of the dopamine spike. And then it wears off, and you start to metabolize it, it wears off. And then people, they feel kind of sedated, and then they feel sort of normal, and then they feel sick or dope sick or in withdrawal. And then what do? They use again. So people are cycling like this all day long between being high and being sick and being high and being sick. And eventually they burn out the endorphins and they can't get high anymore. And then the patient will come in and say, Doc, I can't get high anymore. I'm just trying not to be sick, which is a nightmare. So buprenorphine, on the other hand, or methadone would kind of be the same thing. So the person, takes the buprenorphine in the morning, and it's designed to do this. Okay, so they're not high, they're not sick, they feel normal. Okay, so with agonist therapy, the patient is not high, it stops the withdrawal, it stops the craving, and they will pretty predictably stop using. Okay, this results in decreased overdose mortality, decreased Hep C and HIV transmission, decreased crime, more employment. So those symptoms that we showed you, the W chart, those 11 DSM-5 diagnostic criteria, those start to go away. So that's why it's not replacing one addiction with another. It doesn't look like addiction. It looks like recovery to me. And you would see that if you would come, meet some of my patients, which you could potentially do maybe, and they look normal. So this is the buprenorphine efficacy graph. This was in Sweden. This was people using heroin, buprenorphine versus placebo. And the endpoint was retention in treatment, which is an interesting endpoint. It's very patient-centered, right? They're coming back. So the buprenorphine group had 75% treatment retention at 1 year. That's pretty good. Okay, methadone has better treatment retention, like 95%. And you can see what happened to the treatment retention in the placebo group. It went to 0 pretty quickly, and 25% of the people in the control group died of overdoses. So that's the buprenorphine efficacy. It's very effective in preventing overdose deaths. These are toxicology numbers from DART, which is the methadone program where I work. And So this was the percentage of the toxins that are positive for fentanyl. Okay. So pre-COVID, we were running at 11%. So I can get like 90%, 89% of the toxins to be negative for fentanyl. So you guys before were saying what, like a 5? Like this can really work. This can be like, this is kind of like a 9 over here. Now it kind of was getting worse. This was this advancing wave of the stimulant addiction with the fentanyl in it. This is that progressing. We stopped doing toxins in March of 20 because of COVID, and we were trying to limit the transmission. And we didn't start doing toxins again until the end of 21. So you can see what happened. This is the pandemic. This is the stress and people being stuck at home and not working and not having access to services and the fear and all that. And now it's coming down. It's starting to come down. And this was, I just pulled this off of the website, our tox company's website. And so this was looking at each month in the past year. And you could see that, it's really, maybe it's really starting to come down back towards that 11% where we were. So maybe we're making some progress. So there's a few references. Are there any, that's all I got basically. Do you have any questions from anybody?
People can unmute themselves or just throw it in the chat and I'll try to get them.
Sure. Thank you so much for that talk. This is Michael Dunny. I had a quick question.
Yeah.
I've worked on drug treatment courts.
Yes.
And God, we could talk all day about those areas, but a lot of the clients would come in with opioid use disorder, still with pain. And I recall buprenorphine or Suboxone being prescribed because it had some pain relief. Could you talk a little bit about those kinds of patients that still maybe became addicts or had opioid use disorder because they were using the medication for pain?
Sure.
Well, they still have pain.
Sure. That's very common. Like half of people that are being treated for opioid use disorder will tell you that they have severe chronic pain. If you look at that literature, that's very common. And if you ask people, how did when I start getting the history, I start with, so how did your opioid problem start back in the day? And it's almost always, oh, I was prescribed them. Right. So people get prescribed opioids, and it was often like really inappropriate prescribing. So there are people, you have to kind of look at that whole picture and make a kind of clinically, what we try to do is first separate it. So you try to look at, what is the pain situation and make a really accurate pain diagnosis and what's going on. And what has been tried besides opioids, what's been tried, like, I don't know if you know what a TENS unit is, but I had some back surgery and I had a TENS unit, which is a little nerve stimulator, and that worked great. And so many of my patients, like people just jump right to opioids. So, but our approach with this is first you try to make a really accurate pain diagnosis, because chronic pain is really not a diagnosis. I mean, it's a symptom. So you try to really make an accurate diagnosis, and that might mean talking to the neurosurgeon or talking to the orthopedic surgeon, or have you had films lately, or what's the imaging like, or do you need another MRI or something like that? And then, what have you tried for the pain? And well, we do have people that arrive. This is pretty common, and somebody will arrive at the methadone clinic, and these patients, they kind of they do not like the addict label, and they do not like that narrative that they have addiction, and they're like super focused on the chronic pain addiction. And they'll tell you, doc, I'm not a drug addict. Everybody's telling me that I'm an addict, and I'm not. I just have all this pain, and nobody's treating my pain. And they're like really angry. They're like super angry about it, about how they've been treated. And usually, and there often is like stuff that looks like various substance use disorders. They're using cocaine, and they're using methamphetamine, and they're using fentanyl and they're using alcohol and they're almost always smokers, by the way. And my approach with these folks is I don't label them because that doesn't help. And I'll even tell the patient, I'll say, listen, I don't want to give you a label. I don't think that's helpful. And they start to relax. And then I say, and this is, so there might need to be more evaluation, like another MRI or something, or I might need to talk to the neurosurgeon, but I'll tell them, and they've typically run into all kinds of problems because they were prescribed hydrocodone or oxycodone or all this stuff, and it just turned into a disaster because it turned into opioid use disorder. So they've got opioid use disorder and pain. So, sorry. Must have been somewhere else. Sorry. Anyway, what I tell that person is, listen, I think you've had all these problems from these short-acting opioids. I throw in an explanation of opioid-induced hyperalgesia. So the short-acting opioids sensitize the brain to pain and cause more pain. And I tell people, listen, I've got these two other medications I'd like to talk to you about, buprenorphine or methadone. They both have less opioid-induced hyperalgesia than the short-acting opioids. And there's various pharmacologic reasons for that. And they're good treatments for opioid use disorder. And I tell the patient, if we got you on buprenorphine or methadone, I think it would control your pain a lot better. And it would also control all these other problems that you've been having that I don't want to label them as an addict for. And I think you'd have a lot less pain. And I think you do really well. And they say, wow, nobody's ever talked to me about this before. And when can we start? So that can be a really good solution for people in that situation is buprenorphine or methadone. That's a really good solution, but it's a complicated problem.
Thank you.
So,
Dr. Weissman, am I understanding you have another appointment to move on to?
it can wait a couple of minutes.
Okay. There's another question in the chat from Dr. Daria. What happens when you use methadone for acute treatment without the bup microdosing?
Hi, Arpan, by the way. Arpan did a little research project with us at DART back in the day.
Hi, Dr. Weissman. How are you?
Hi. It's nice to hear from you. So you're asking, so somebody comes in like for detox, and if you give them methadone, is that what you're asking?
Just the example you gave of the patient, you asked a question, what would happen if you gave them fentanyl? And then the answer was they would have severe withdrawal. In the same example, what would happen if you gave methadone instead of buprenorphine?
Oh, they're fine. They're fine because methadone is a full agonist. So you don't get precipitated withdrawal using methadone. That's why it's very commonly used in the detox unit for opioid detox. Little methadone taper for 5 days.
Thank you.
So I think of those graphs all the time. That's how I put that together.
Dr. Meyer.
I really liked your talk and your personal perspective on it as well. So thank you for doing that. That was really great. I like those graphs that you showed too, especially the dopamine graph showing this, the reinforcement signal spike.
Mm-hmm.
But then when you went on into treatment, I felt like, it seems like treatment is really focused on withdrawal management, right?
Mm-hmm.
And less so at targeting that drug reinforcement. So like, I'm wondering if there's ways that you can work into reducing the drug reinforcement in some of these treatment models, like with a run-up sort of method, while they're on, like, let's say buprenorphine, while they're still actively taking drugs, because that could help reduce some of that reinforcement signal and potentially reduce the incentive value of the drug itself, which it feels like the withdrawal management programs don't necessarily do.
That's a very interesting question, to try to separate out the reinforcement from the withdrawal. And I think currently we don't really do that. I don't know quite how you could do that. That's more, that's more like recovery. That's where recovery comes in. I think it's kind of reconfiguring the salience and reinforcement of normal things. And I had this discussion with a medical student today, even though she was asking me about, well, why are we talking about all this God stuff and the AA stuff? Like, what does that have to do with anything? And I think a lot of that is that's so, because I think the midbrain is also about some of these, really important, heartfelt, really valuable things, and like, which, that's maybe spirituality. And I think when people are engaging in a recovery program and going to meetings and having these, interactions with people, and that's that interpersonal thing going on. And I think that is reinforcing, and that is rebuilding in a healthy way some of these dopaminergic pathways in the midbrain. So I think that's where that comes in. And it's a good point. The withdrawal management, that's kind of a start, as we can calm down the brain, but then where are you going to go from there? Where does your life go from there in terms of rebuilding normal salience and normal reinforcement and normal value? Because when people are really, really in addiction, nothing else has any meaning or value. And the things addiction uses whatever the person values most, it destroys. Right. And nothing else has any meaning. That's why it always amazes me, the women that come in and they will give up their children to use. Because I think that's, I've seen that with my wife and our kids, how intensely I can only imagine. I don't think I can really know what that means for my wife, how she feels about her own children. And that women can do that and give that up in the service of the addiction. That shows you the power of it, and how it destroys the meaning and salience and value of anything else in life. So I think that takes a long time to rebuild that. And that's what a recovery program is about.
And I think a pharmacological adjunct could help restructure
Right.
salience, right? You can interfere with drug salience while maintaining or even require some alternate natural social reinforcer to reinforce more adaptive kinds of behaviors, like interacting with your family.
That's an amazing idea.
Dr. Weissman, your talk today, I've done a bunch of these over the last couple of years. It was engaging. It was very, very much appreciated.
Thanks.
Thank you, Dr. Clark, for bringing Dr. Weissman to the conversation. And I can only say that we appreciate the fact that you were willing to kick this off, as we have Dr. Valco coming up in a few weeks, which is super exciting based on everything that's happening in the research climate at the moment. So thanks so much for taking the time to do it, and for everybody that joined today. It was very, very engaging and much appreciated.